The fire within, a definitive protocol for extinguishing Gerd. It begins as a subtle discomfort, a phantom heat rising in the chest, before escalating into a relentless, searing biological betrayal. Gastroesophageal reflux disease, GERD, is not merely indigestion, it is the systematic erosion of the esophagus by hydrochloric acid potent enough to dissolve metal. This condition plagues millions, fueled by modern excess and physiological dysfunction. Yet this internal conflagration is not inevitable. Through rigorous lifestyle calibration and strategic intervention, we can silence the burn forever. Here is the ultimate dossier on neutralizing the threat, starting with the fundamental physics of digestion. The volumetric crisis: eat smaller meals. To understand the catastrophic failure of the upper gastrointestinal tract that constitutes gastroesophageal reflux disease, GERD, one must first appreciate the stomach not merely as a biological organ, but as a high-pressure vessel subject to the immutable laws of physics and fluid dynamics. The primary mechanical cause of acid reflux is often not a defect in the acid itself, but a violation of volumetric capacity. The human stomach is an evolutionary marvel, a muscular sac designed to expand and accommodate sustenance, yet it possesses a critical tipping point. When we consume the standard Western meal, often characterized by excessive caloric density and physical volume, we are essentially overpressurizing a hydraulic system that relies on a single fragile valve to maintain containment. This valve, the lower esophageal sphincter, LES, is the unsung hero of the digestive system, a ring of smooth muscle that acts as the gatekeeper between the sterile, neutral environment of the esophagus and the chaotic, acidic churn of the stomach. The imperative to eat smaller meals is not a trite dietetic suggestion. It is a fundamental engineering requirement for preserving the integrity of the LES. When a large volume of food is ingested, the stomach distends. This distension is the catalyst for a cascade of physiological events known as gastric accommodation. In a healthy scenario, the fundus, the upper part of the stomach, relaxes to accept the food. However, in the context of a massive meal, the intragastric pressure rises precipitously. This pressure exerts an outward force against the stomach walls and, crucially, an upward force against the LES. According to the law of Laplace, wall tension increases with the radius of the vessel. As the stomach stretches to accommodate a large dinner, the tension on the gastric wall pulls at the sphincter, effectively shortening its length and compromising its ability to form a tight seal. It is a mechanical failure born of excess. The valve is simply overpowered by the sheer volume of the cargo it is meant to contain. Furthermore, the consumption of large meals triggers a physiological phenomenon known as transient lower esophageal sphincter relaxations, TLESRs. These are spontaneous moments where the sphincter relaxes without the act of swallowing, while TLESRs are a normal bodily function necessary for venting swallowed air. The frequency of these relaxations increases dramatically when the stomach is distended. A stomach stretched to its limit sends urgent signals via the vagus nerve to the brainstem, which in turn commands the sphincter to relax to relieve the pressure. It is a biological safety valve gone awry. In attempting to prevent the stomach from bursting, the body inadvertently opens the floodgates for gastric acid, bile, and pepsin to surge upward into the esophagus. This is the heartburn sensation, a chemical burn occurring in real time, as the esophageal lining, known as the squamous epithelium, is subjected to substances with a pH often as low as 1.5. The historical context of meal sizing offers a fascinating window into why this has become a modern epidemic. For the vast majority of human evolution, Homo sapiens were grazers and opportunistic eaters. The hunter-gatherer existence did not guarantee 3 massive regimented meals a day. Our ancestors ate what they could find, often in smaller, irregular quantities. The human digestive system evolved to handle these moderate inputs efficiently. The concept of the heavy meal, particularly the massive evening dinner, is a relatively recent cultural invention, solidified by the Industrial Revolution, which regimented work hours and pushed the bulk of caloric intake to the end of the day. We are currently operating ancient biological machinery in a modern environment of caloric abundance. The stomach, designed for scarcity and moderation, is now routinely subjected to feasts that would have been rare anomalies in the Paleolithic era. This evolutionary mismatch is the silent driver behind the global explosion of reflux diagnoses. Beyond the mechanics of pressure, the chemistry of large meals exacerbates the issue. A larger quantity of food requires a larger quantity of acid for digestion. The parietal cells in the stomach lining respond to the presence of protein and the distension of the stomach by pumping out hydrochloric acid. A massive meal creates a massive acid load. Moreover, there is the phenomenon of the acid pocket. Research utilizing high-resolution manometry and pH monitoring has visualized a layer of unbuffered, highly acidic gastric juice that sits on top of the food chyme, right near the gastroesophageal junction. In a large meal, this acid pocket is pushed physically closer to the esophagus. It hovers there, a toxic cloud waiting for the slightest relaxations of the sphincter or a shift in body position to breach the perimeter. This brings us to the critical what to do protocol, stopping eating and waiting 2 to 3 hours before lying down. This advice is rooted in the physics of gravity and the rate of gastric emptying. Digestion is a slow, churning process. The stomach must grind food down to particles smaller than 2 millimeters before they can pass through the pyloric sphincter into the small intestine. This process, depending on the composition of the meal, takes hours. When an individual eats a large meal and immediately lies down, they are removing the assistance of gravity. In an upright position, gravity helps keep the gastric contents at the bottom of the stomach. In a supine, lying down position, the stomach contents pool against the LES. If the meal was large, the pressure is already high. Adding the horizontal vector turns the stomach into a tipped flask. The acid no longer needs to fight gravity to reach the esophagus, it simply flows there. The intervention strategy therefore requires a radical restructuring of daily life. It demands the abandonment of the 3 squares model in favor of 5 or 6 micromeals. This approach keeps the stomach in a state of manageable capacity, never fully empty, which can cause acid buildup, but never fully distended. It reduces the amplitude of acid secretion spikes and minimizes the mechanical stress on the LES. When reflux does strike, the instruction to wait 2 to 3 hours is non-negotiable. It is the approximate time required for the stomach to empty 50 to 70% of its contents, reducing the volume to a safe level for sleep. This is not merely about comfort, it is about preventing the nocturnal aspiration of acid, where reflux reaches the throat and enters the lungs, causing chronic coughs, pneumonia, and long-term respiratory damage. The discipline to stop eating, to withstand the social pressure of the late-night feast, and to respect the volumetric limits of one's own anatomy is the first, most crucial line of defense in the war against GERD.
2. The chemical insurgency. Avoid trigger foods. If the size of the meal represents the physical assault on the esophageal fortress, the composition of the meal represents the chemical insurgency. Avoiding trigger foods is not simply a matter of preference or mild dietary adjustment. It is an act of tactical exclusion, removing agents of chaos that are chemically designed to sabotage the digestive process. The human diet is replete with compounds that, while culturally celebrated and culinarily delightful, act as potent relaxants for the lower esophageal sphincter or as direct irritants to the delicate mucosa of the esophagus. To prevent GERD is to understand the molecular interaction between what we ingest and how our neurohormonal systems respond. We must analyze the big 3 categories of chemical saboteurs: fats, spices, and intrinsic acids. Let us begin with the most insidious offender, dietary fat. In the modern culinary landscape, fat is flavor. It provides the mouthfeel, the satiety, and the richness that defines comfort food. However, from a gastroenterological perspective, high-fat foods are a strategic nightmare. When lipids, fats, enter the duodenum, the first section of the small intestine, they trigger the release of a hormone called cholecystokinin, CCK. CCK is vital for digestion. It signals the gallbladder to release bile to emulsify the fats. However, CCK has a secondary, systemic effect. It significantly decreases the pressure of the lower esophageal sphincter. It acts as a sedative for the valve. By consuming a meal high in fried foods, marbled meats, or heavy creams, one is chemically instructing the body to unlock the door to the stomach. Furthermore, fat drastically delays gastric emptying. Lipids are the most energy-dense macronutrient and require the most complex breakdown process. A fatty meal sits in the stomach for hours longer than a protein-rich or carbohydrate-rich meal. This creates a double-hit scenario. The fat has chemically relaxed the sphincter via CCK, and simultaneously it keeps the stomach full and pressurized for an extended duration. The stomach becomes a stagnant pool of acid and grease, waiting for the opportunity to reflux. The prevention here requires a rigorous audit of lipid intake. It involves shifting from deep-fried substrates to baking, steaming, or grilling. It means understanding that a single slice of pepperoni pizza is a delivery system for both volume and LES-relaxing grease.
A perfect storm for esophageal injury. Next, we must confront the heat of the culinary world, spicy foods. The active component in chili peppers, capsaicin, is a masterpiece of botanical defense. Plants evolved capsaicin to deter mammals from eating their fruit, as mammals grind seeds, whereas birds, who are immune to capsaicin, spread them. Humans, in our culinary hubris, learn to love the burn. However, for the GERD sufferer, capsaicin is an aggressive irritant. It does not technically burn tissue in the thermal sense, but it binds to TRPV1 receptors, which are responsible for detecting heat and pain. When capsaicin contacts the inflamed lining of an esophagus already damaged by acid, it triggers intense neurogenic inflammation. It heightens visceral sensitivity, meaning that even a small amount of normal acid reflux will feel significantly more painful. Moreover, some studies suggest that capsaicin can slow gastric accommodation, increasing the feeling of fullness and distension. The prevention strategy regarding spice is often the most culturally difficult, as spice is central to the identity of many global cuisines. Yet, the biological reality dictates that for a compromised esophagus, chili oil, curry pastes, and hot sauces are essentially caustic agents. The removal of these items allows the esophageal mucosa time to heal without being subjected to daily chemical bombardment. The third pillar of the chemical insurgency involves foods that are intrinsically acidic or contain specific methylxanthines, such as chocolate, citrus, and tomatoes. Chocolate is perhaps the most tragic loss for the reflux sufferer. It contains theobromine, a compound naturally found in the cacao plant. Like caffeine, theobromine is a methylxanthine, which has been shown to reduce LES pressure. Chocolate is also typically high in fat and contains serotonin, both of which further encourage the sphincter to relax. It is the perfect storm food, a trifecta of fat, cocoa, and relaxants that almost guarantees reflux in susceptible individuals. Citrus fruits, lemons, oranges, grapefruits, and tomatoes operate differently. They are highly acidic in their own right, with pH levels often falling between 3 and 4. While the stomach is designed to handle this acidity, the esophagus is not. If the LES is weak, consuming highly acidic foods is akin to pouring lemon juice on an open wound. The acid activates pepsin, the stomach enzyme responsible for breaking down protein.
Pepsin can remain dormant in the tissues of the throat and esophagus. When it comes into contact with dietary acid, like a tomato sauce or orange juice, it can be reactivated, causing the enzyme to start digesting the cells of the esophagus itself. This is a mechanism of autodigestion that contributes to the severity of erosive esophagitis. The operational protocol, what to do, revolves around the concept of the elimination diet and the washout period. This is an investigative process where the patient becomes the scientist. If symptoms worsen, one cannot simply guess the culprit, one must track it. The recommendation to remove triggers for 7 to 14 days is based on the tissue turnover rate. The esophageal lining needs a reprieve from the assault to begin regeneration. By systematically eliminating fried foods, chocolates, spices, and tomato-based products for 2 weeks, the patient can establish a baseline of quiet. Once the inflammation subsides, foods can be reintroduced one by one to test individual tolerance. This is crucial because Gerd is a heterogeneous disease. What triggers a firestorm in one patient may be benign in another. Some can tolerate tomatoes but not chocolate. Others are decimated by onions, which contain fermentable fibers that increase gas pressure, but can handle spice. The 7 to 14-day elimination is not a life sentence. It is a diagnostic calibration. It allows the individual to construct a personalized safe list and a danger list. This process requires a psychological shift. We are conditioned to view food as a reward, a comfort, and a right. The Gerd prevention protocol frames food as fuel with specific chemical properties. It demands a level of mindfulness that runs counter to the fast food, instant gratification culture. It requires reading labels for hidden fats, inquiring about preparation methods at restaurants, and possessing the stoicism to decline the chocolate dessert or the spicy appetizer. It is a defense of the interior, a conscious decision to prioritize the structural integrity of the digestive tract over the fleeting pleasure of the palate. By mastering the chemistry of intake, one effectively disarms the enemy before it can breach the gates.
3. The gravitational imperative, the chronobiology of postprandial recumbency, and the 3-hour window. To comprehend the absolute necessity of maintaining an upright posture following caloric intake, one must first accept a fundamental truth about human anatomy. We are designed to digest vertically. The stomach, for all its complex enzymatic capabilities and muscular contractions, is ultimately a gravity-dependent vessel. Throughout the long arc of human evolution, the consumption of food was an active process, typically followed by continued movement, hunting, gathering, or migrating. The modern phenomenon of the postprandial slump, the nearly irresistible urge to recline on a sofa or retreat to bed immediately after a heavy meal, is a behavioral anomaly that places catastrophic stress on the gastroesophageal junction. Entry number 3 in the prevention protocols is not merely a suggestion to avoid laziness, it is a strict commandment based on fluid dynamics and the geometry of the stomach. When an individual lies down shortly after eating, they are effectively removing the single greatest ally the lower esophageal sphincter, the LES, possesses, the force of gravity. When the human body is upright, the stomach acts as a J-shaped reservoir. The heavy slurry of chyme, the mixture of food and acid, settles in the lower portion of the organ, the antrum, where the muscular walls work to grind it down and push it through the pyloric sphincter into the small intestine. In this vertical orientation, the upper portion of the stomach, the fundus, is largely filled with gas, the gastric bubble. This gas bubble sits directly beneath the LES. Because the sphincter is designed to vent gas, belching, but block liquid, this arrangement is physiologically stable. However, the moment the body shifts to a horizontal plane, the contents of the stomach are redistributed. The stomach transforms from a vertical tank into a horizontal tube. The fluid level shifts, washing over the fundus and pooling directly against the delicate valve of the LES. If that valve is even marginally incompetent, weakened by H, diet, or anatomical hernia, the liquid will breach the barrier. This is the tipping point in the literal sense. By lying down, the sufferer effectively turns their stomach into a tipped-over bucket, challenging the seal of the lid with the full weight of its corrosive contents. The science behind the 2 to 3 hour rule is rooted in the rate of gastric emptying.
This is not an arbitrary number plucked from folklore, it is a calculation based on the half-time of digestion. For a standard mixed meal containing proteins, fats, and carbohydrates, the stomach requires approximately 90 to 120 minutes to empty 50% of its contents into the small intestine. During this critical window, the intragastric pressure is at its peak, and the volume of acid production is at its maximum, the acid tide. If one reclines during this phase, the risk of reflux is nearly guaranteed for those with Gerd. The stomach is distended, actively churning, and flooded with hydrochloric acid. By waiting 3 hours, the individual allows the stomach to clear the vast majority of the meal, reducing the volume to a safe level, where even if one lies down, there is not enough fluid to reach the high water mark of the esophagus. This period of upright activity acts as a safety buffer, a quarantine period where the volatile chemical reactions of digestion can occur safely in the lower abdomen, far from the sensitive tissues of the throat. The cultural implications of this rule are profound and disturbing. The modern Western lifestyle is engineered to violate this biological law. The structure of the contemporary workday pushes the largest meal of the day to the late evening. We return home exhausted, consume a calorically dense dinner at 7 or 8 p.m., and almost immediately transition to sedentary leisure, sitting slumped on a couch or lying in bed watching television. This dinner-to-docility pipeline is a primary driver of the Gerd epidemic. We have synchronized our highest caloric intake with our lowest period of physical activity and our most horizontal posture. The what-to-do protocol for this entry demands a radical restructuring of the evening routine. It requires the Gerd sufferer to view the post-dinner window not as relaxation time, but as an active phase of the digestive cycle. If exhaustion necessitates rest, the instruction to sit up is non-negotiable. This does not mean propping oneself up on an elbow, which creates lateral pressure on the stomach. It means maintaining a torso angle of at least 45 to 60 degrees. Furthermore, the physiological consequences of recumbency go beyond simple fluid mechanics. They involve the cessation of secondary peristalsis. When we are upright and awake, we swallow frequently, often unconsciously.
Each swallow triggers a peristaltic wave that strips the esophagus clean of any stray acid that may have splashed up. Gravity assists this clearance. When we lie down and drift into the early stages of sleep or deep relaxation, the swallowing reflex diminishes significantly. Saliva production, which is rich in bicarbonate and neutralizes acid, drops to near zero. Therefore, if acid escapes into the esophagus because the patient lay down too soon, it does not just burn momentarily, it sits there. Without gravity to pull it back down and without saliva to wash it away, the acid dwells on the esophageal lining, causing deep chemical burns. This is why the wait is critical. It ensures the acid is gone before the body's natural cleaning mechanisms shut down for the night. The preventative strategy here also intersects with the concept of the working dinner or late-night social eating. For the reflux patient, a late reservation is a medical hazard. The discipline required to stop eating 3 hours before bed often means eating dinner at 5:30 or 6 p.m., a schedule that conflicts with modern social norms. Yet the biological reality remains. The stomach does not care about social schedules. It operates on a fixed timeline of enzymatic breakdown and muscular emptying. Violating this timeline by lying down prematurely is akin to shaking a bottle of soda and then laying it on its side with the cap loose. The pressure will find a way out. When the what-to-do contingency is triggered, when one must rest due to illness or extreme fatigue shortly after eating, the mechanics of sitting up must be precise. The use of a recliner chair is often superior to a bed in this specific context. A recliner keeps the pelvis lower than the chest, maintaining the gravitational gradient. However, one must be wary of the slump, where the midsection compresses, increasing abdominal pressure. The ideal posture is one of elongation, keeping the spine straight to allow the stomach maximum room to churn without compressing the gastric bubble. This entry ultimately teaches us that digestion is a kinetic activity. It requires space, time, and the correct orientation. To ignore the 3-hour rule is to ignore the fundamental physics of the container that keeps us alive, inviting a chemical backwash that slowly erodes the machinery of the throat.
4. The geometry of sleep, inclined bed therapy, and the left lateral decubitus defense. If the daylight hours are a battle against pressurized volume, the night is a war against silent exposure. Nocturnal gastroesophageal reflux, and Gerd, is the most destructive form of the disease, associated with the highest risks of complications such as Barrett's esophagus, esophageal adenocarcinoma, and severe laryngitis. During the day, we have defenses. We swallow, we drink water, we stand up. At night, we are defenseless. We lie paralyzed in sleep while the acid pools. Entry number 4. Elevating the head while sleeping is not merely a comfort adjustment. It is an architectural intervention designed to weaponize gravity during our most vulnerable hours. However, the execution of this strategy is often misunderstood, leading to ineffective measures that fail to protect the esophagus. True prevention requires a precise understanding of angles, anatomy, and the plumbing of the upper GI tract. The instruction to elevate the head is somewhat of a misnomer that leads to the common failure of pillow stacking. Many sufferers attempt to treat night reflux by piling 2 or 3 pillows under their head. This is mechanically disastrous. While the head is raised, the torso remains flat and the neck is bent forward. This flexion of the neck can actually increase intra-abdominal pressure and compress the throat, potentially worsening reflux or obstructing the airway, exacerbating sleep apnea, which feeds back into Gerd. The medical requirement is the elevation of the thorax, not just the cranium. The entire upper body, from the hips to the head, must be on an inclined plane. The target geometry is an elevation of 15 to 20 centimeters, 6 to 8 inches, at the head of the bed, creating a continuous slope. This angle is sufficient to prevent the migration of the acid pocket into the esophagus. Even if the LES relaxes during sleep, the force of gravity on the incline makes it difficult for the fluid to climb the uphill gradient of the esophagus. To achieve this, the gold standard is the mechanical elevation of the bed frame itself. Placing bed risers, sturdy blocks of wood or plastic, under the two legs at the head of the bed physically tilts the entire sleeping platform. This creates a stable, non-compressible slope that does not shift during the night. For those who cannot alter their bed frame, the alternative is a wedge pillow. However,
the density and length of the wedge are critical. It must be long enough to support the lower back, tapering gently up to the head, ensuring the stomach is positioned lower than the throat. This is a lifestyle modification that transforms the bedroom into a therapeutic space. It acknowledges that for the GERD patient, a flat surface is a hostile environment. The physics of the incline utilize the clearing volume principle. Even if a small amount of acid breaches the valve, the slope allows it to drain back into the stomach rapidly, drastically reducing the contact time between the acid and the mucosa. But elevation is only half of the nocturnal equation. The what to do component of this entry introduces the critical concept of sleep positioning, the left lateral decubitus. The human stomach is not a symmetrical bag. It is curved, with the greater curvature on the left and the lesser curvature on the right. The esophagus enters the stomach at an angle, not directly at the top. This asymmetry means that the position of the body determines the position of the fluid relative to the exit valve. When a person sleeps on their right side, the stomach is positioned above the esophagus. Gravity drains the gastric contents directly toward the LES. It effectively turns the sphincter into the lowest point of the container, placing it under constant hydrostatic pressure. Right side sleeping is statistically correlated with longer and more frequent reflux episodes. Conversely, when a person sleeps on their left side, the anatomy works in their favor. The stomach hangs below the esophagus. The gastric fluids pool in the belly of the stomach, away from the valve. The LES sits high and dry, acting as an air vent rather than a fluid drain. Studies have shown that sleeping on the left side can drastically reduce acid exposure time. The combination of these two physical interventions, elevation and left side positioning, creates a fortress against night reflux. The elevation prevents the climb, and the left side position sequesters the acid in the safety of the gastric reservoir. The implementation of this protocol, however, requires overcoming significant physical and behavioral hurdles. Humans move during sleep. We roll, shift, and adjust. Maintaining the left side position often requires training or physical aids, such as body pillows placed behind the back to prevent rolling over to the right.
The what to do regarding waking up with reflux is a crisis management protocol. If a patient wakes up choking on bile or coughing, a sign of aspiration, the immediate response must be to stand up and drink water to wash the acid back down. But the prevention lies in the architecture of the bed. The modern market has responded with adjustable bed bases, formerly the domain of hospitals, now entering the consumer luxury market. These bases allow for the zero-gravity or anti-snore positions that elevate the head at the touch of a button. For the serious GERD sufferer, this is not a luxury. It is medical equipment. We must also consider the silent damage of night reflux. Many patients do not wake up with heartburn. Instead, they suffer from silent reflux, or LPR, where microscopic droplets of acid mist reach the larynx and sinuses during sleep. They wake up with a hoarse voice, a chronic cough, or a metallic taste, unaware that their esophagus was bathed in acid for hours. This makes the elevation rule universal, regardless of whether one feels the burn at night. The damage is cumulative. The esophageal lining can undergo metaplasia, changing its cell structure to resemble the intestine, Barrett's esophagus, as a survival mechanism against this chronic nocturnal acid bath. This cellular change is a precursor to cancer. Therefore, elevating the head of the bed is a direct anti-carcinogenic strategy. The philosophical implication of this entry is that the GERD sufferer can never truly let go in the same way a healthy person can. Even in sleep, the body must be managed. The bedroom becomes a place of strategy. The 15 to 20 centimeter lift is a physical manifestation of the disease's burden, a constant visible reminder that the natural horizontal state of rest is dangerous. Yet once the body adapts to the incline and the left side dominance, the results are often miraculous. The respiratory system heals, the morning voice clears, and the esophagus is granted a nightly truce. This is the ultimate passive prevention, engineering the environment so that gravity does the work while the conscious mind sleeps. It is the final line of defense, protecting the gateway to the body when the sentinel is unconscious.
The fifth entry in the prevention protocol addresses a subject that is often clouded by aesthetic vanity or social stigma, yet in the context of gastroesophageal reflux disease (GERD), it is strictly a matter of hydraulic engineering. Maintain a healthy weight is a benign phrase that masks a violent physiological reality. To understand why excess body mass, specifically central adiposity or belly fat, is the engine of acid reflux, one must visualize the abdomen not as a collection of organs, but as a pressurized fluid-filled compartment.
The relationship between body mass index, BMI, and GERD symptoms is statistically linear and devastatingly consistent. This is not merely about the load the body carries, it is about the crush the organs endure. The pathology of obesity-induced reflux is a tale of two forces, the mechanical compression of the stomach and the biochemical sabotage of the sphincter, creating a perfect storm that forces gastric contents upward against gravity and anatomical barriers. The primary mechanism at play is the elevation of intra-abdominal pressure, IAP. In a healthy lean individual, the pressure within the abdominal cavity is roughly neutral or slightly positive relative to atmospheric pressure. The thoracic cavity, chest, conversely, maintains a negative pressure to facilitate lung inflation. This pressure gradient, positive in the belly, negative in the chest, is maintained by the diaphragm, a crucial muscle that serves as the ceiling of the abdomen and the floor of the thorax. The lower esophageal sphincter, LES, sits precisely at this volatile border. When an individual accumulates significant visceral adipose tissue, the deep fat that wraps around the liver, pancreas, and intestines, the available volume within the abdominal cavity shrinks. The fat competes for space with the organs. Since the abdominal wall has limited elasticity, this internal crowding drastically increases IAP. The stomach, a hollow flexible sac, is literally squeezed by the surrounding visceral fat. This is the squeeze phenomenon. The pressure inside the stomach, intragastric pressure, rises until it exceeds the closing pressure of the LES. When this threshold is breached, the valve is forced open from below, not by a failure of the muscle itself, but by the sheer overpowering force of the pressure beneath it.
This mechanical assault is often the precursor to the anatomical failure known as a hiatal hernia. The diaphragm contains a small opening called the hiatus, through which the esophagus passes to join the stomach. In a lean body, the diaphragm reinforces the LES, acting as an external clamp during moments of high pressure, such as coughing or straining. However, in the presence of central obesity, the constant upward force exerted by the pressurized abdomen pushes the upper part of the stomach, the fundus, through the hiatus and into the chest cavity. This is a catastrophic structural failure. Once the stomach is herniated into the chest, the LES loses the support of the diaphragm. It is left stranded in the negative pressure environment of the thorax, where it is significantly weaker and prone to spontaneous relaxation. The healthy weight mandate is therefore a strategy to physically pull the stomach back down into the abdomen and restore the integrity of the diaphragmatic pinchcock. It is about reducing the siege pressure on the abdominal floor so that the anatomy can return to its evolutionary alignment. Beyond the mechanics, recent deep dive research into the endocrinology of obesity has revealed a biochemical betrayal. Adipose tissue is not inert storage, it is a metabolically active organ. Visceral fat cells secrete a cocktail of cytokines and hormones known as adipokines, including tumor necrosis factor alpha, TNF-alpha, interleukin-6, IL-6, and leptin. These compounds create a state of chronic, low-grade systemic inflammation. Crucially, studies suggest that these inflammatory cytokines may have a direct inhibitory effect on smooth muscle function. The LES is a smooth muscle. The hypothesis is chilling. The belly fat is not just pushing on the valve, it is chemically signaling the valve to relax. This humoral theory of Gerd suggests that the inflammatory mediators released by visceral fat circulate in the blood, reaching the esophagus and weakening the neuromuscular integrity of the sphincter. Thus, the overweight Gerd patient is fighting a war on two fronts, a physical war of pressure and a chemical war of hormonal inhibition. The prevention aspect here focuses heavily on the reduction of visceral fat, which is distinct from subcutaneous fat, the pinchable fat under the skin. Visceral fat is metabolically stubborn but highly responsive to activity. This leads to the specific guidance on daily walking.
Walking is not prescribed here solely for caloric burn, but for its biomechanical effects on gastrointestinal motility. The act of walking engages the core muscles and the diaphragm in a rhythmic pattern that gently massages the intestines, promoting peristalsis and gastric emptying. A sedentary lifestyle allows the stomach contents to stagnate, increasing the window of opportunity for reflux. By walking, particularly after meals, the patient actively recruits gravity and muscular contraction to move food out of the danger zone of the stomach and into the safety of the small intestine. It is a manual override of a sluggish digestive system. Furthermore, the dietary component of weight management, specifically the reduction of sugary drinks, addresses the fermentation factor. A diet high in refined sugars and fructose acts as rocket fuel for the bacteria in the gut. When these bacteria ferment sugar, they produce gas, hydrogen, and methane. In a lean person, this gas is vented easily. In an obese individual with already high IAP, the additional gas acts as a pneumatic wedge, further distending the stomach and blowing open the LES. Reducing sugar is thus a pressure release strategy. It minimizes the internal gas production that contributes to the overall distension of the gastric reservoir. The cultural trajectory of this entry is complex. We live in an era of body positivity, which is socially progressive but medically complicated when discussing Gerd. The esophagus does not care about social acceptance, it responds only to physics. The rise of central adiposity in the Western world has tracked almost perfectly with the explosion of esophageal adenocarcinoma, a cancer caused by chronic reflux. The scary reality is that even skinny fat individuals, those with normal BMI but high visceral fat, are at risk. The future of GERD prevention may rely less on the scale and more on the tape measure. The waist-to-hip ratio is becoming the gold standard metric for reflux risk. If the waist is significantly larger than the hips, the hydraulic risk is established. The what-to-do protocol for the overweight sufferer is a long-term commitment to decompression. It involves recognizing that every pound of visceral fat lost is a reduction in the hydrostatic pressure challenging the LES. If the patient is overweight and suffering from reflux, the initial intervention is not necessarily a proton pump inhibitor, but a metabolic intervention.
The immediate action of reducing sugary drinks serves as a triage maneuver to stop the gas bloat cycle. The long-term action is the remodeling of the body's core. It is a harsh truth, but for many, the cure for GERD is not in a pill bottle, but in the physical reduction of the abdominal mass that is slowly crushing their internal organs. The stomach requires room to operate. Weight management is simply the act of giving the organ the space it needs to keep its contents contained.
6. The external corset, fashion, compression syndromes, and the artificial stenosis of the abdomen. If obesity is the internal siege of the stomach, tight clothing is the external blockade. Entry number 6, Avoid Tight Clothing Around the Waist, explores how human vanity and fashion trends have inadvertently engineered a mechanical crisis for the digestive system. This is an investigation into the Spanx effect, the skinny jean syndrome, and the historical recurrence of self-strangulation for the sake of silhouette. While the biological imperative of the stomach is to expand to accommodate nutrition, the aesthetic imperative of modern fashion is to compress, flatten, and restrict. When these two forces collide, the path of least resistance is upward, driving acid into the esophagus. This entry demands a re-evaluation of our wardrobe through the lens of Pascal's principle. Pressure applied to a confined fluid is transmitted undiminished in every direction. When we cinch the waist, we do not make the stomach disappear, we merely displace its pressure, turning our clothes into a torture device for the lower esophageal sphincter, LES. The physics of this phenomenon are brutally simple yet often overlooked by both patients and clinicians. The stomach is situated directly beneath the rib cage in the epigastric region. When a person consumes a meal, the stomach requires significant volumetric expansion. A standard meal can increase the stomach's volume from 50 milliliters empty to over 1 liter full. This expansion must go somewhere. In a natural state, the abdominal wall distends outward, the food baby phenomenon. However, if this outward expansion is physically blocked by a rigid belt, high-waisted denim, or compression shapewear, the force is redirected. The stomach is squeezed between the spine in the back and the clothing in the front. The pressure inside the gastric chamber skyrockets. Since the pyloric sphincter, the exit to the intestines, is regulated by a slow release mechanism, the pressure seeks the immediate release valve, the LES. The tight waistband effectively acts as a tube of toothpaste being squeezed in the middle. The contents are forced out of the top. This issue has historical roots that mirror the history of GERD itself. In the Victorian era, the corset was a primary cause of visceroptosis and dyspepsia. Women fainted not just from shallow breathing but from the fatal response to extreme gastric compression. While the bone-crushing corsets of the 19th century have vanished, they have been replaced by a more insidious form of restriction, high-tensile synthetic fabrics. Modern shapewear is designed specifically to defy physics, compressing soft tissue to create a smooth line. For a GERD sufferer, this is catastrophic. These garments apply a uniform, relentless pressure across the entire abdominal wall, maintaining high intra-abdominal pressure IAP throughout the day. Unlike a corset which might be loosened, shapewear is often worn for 10 to 12 hours straight, keeping the stomach under siege from breakfast until bedtime. This chronic compression desensitizes the nerves and creates a new normal of high pressure that the LES eventually fails to contain. The belt is perhaps the most common and overlooked culprit, particularly for men. The mechanics of the belt are exacerbated by the modern sedentary lifestyle. When a person stands, a belt may feel comfortable. However, when they sit, in a car, at a desk, or at a dinner table, the geometry of the body changes. The distance between the hips and the ribs shortens, and the abdominal contents are compressed. A rigid leather belt acts as a fulcrum, digging into the lower abdomen and forcing the visceral contents upward. This is known as the tight belt syndrome. It is particularly dangerous during the postprandial, after eating window. A businessman who eats a heavy lunch and then sits at his desk with a tight belt is creating a pressurized chamber in his gut. The belt prevents the necessary post-meal distension, forcing the acid pocket directly into the esophagus. The what-to-do advice to loosen clothing immediately is a literal medical intervention. Releasing the belt by 1 or 2 notches can drop intragastric pressure significantly within seconds, often providing instant relief from heartburn. The trend of high-waisted pants creates a similar tourniquet effect directly over the stomach. Unlike low-rise jeans which sit on the hips, bones, high-waisted trousers sit on the soft tissue of the abdomen. They button directly over the gastric region. When the wearer sits, the waistband
sound cuts into the stomach, effectively bifurcating the organ. This creates an hourglass deformity of the stomach itself, trapping gas and acid in the upper chamber, the fundus, and preventing it from draining down. This trapped pocket of acid has nowhere to go but up.
The psychological aspect of this is potent. People wear tight clothes to feel held in or slimmer, but the physiological cost is the erosion of their esophageal lining. The prevention here requires a fashion audit. It demands the wearing of clothes that allow for a 2-finger gap at the waist when sitting down. If the clothing leaves a red indentation on the skin after removal, it is too tight for a GERD patient. The what to do protocol extends to the immediate management of a reflux attack. If heartburn strikes, the first physical action should be the removal of constriction. This is often socially awkward but medically necessary. It involves unbuttoning the pants, removing the belt, or taking off the shapewear. This decompression allows the abdominal wall to relax and expand, instantly lowering the pressure gradient across the diaphragm. It allows the stomach to drop back into its natural position. The relief is often described as immediate, proving the mechanical nature of the problem. Culturally, we are witnessing a potential shift with the rise of athleisure. The normalization of elastic waistbands, drawstrings, and softer fabrics is an accidental public health victory for GERD prevention. These garments expand with the wear. They accommodate the postprandial swell rather than fighting it. However, the counter-trend of compression gear for athletic performance reintroduces the risk. Runners and gym goers who wear extreme compression tights while exercising and creating high intra-abdominal pressure through exertion are often baffled by their exercise-induced reflux. The culprit is often the gear itself. Ultimately, this entry forces us to confront the reality that our bodies are dynamic volumes, not static sculptures. The stomach needs to breathe. It needs to swell, churn, and empty without restriction. By encasing our torsos in rigid denim, leather, and spandex, we are fundamentally incompatible with our own biology. The prevention of GERD requires a surrender of the silhouette in favor of the mechanism. It asks the sufferer to prioritize the function of the valve over the flatness of the stomach. In the war against acid, the first step of disarmament is often as simple and as difficult as undoing the top button.
7. The toxic synergy, chemical erosion, mucosal defense failure, and the nicotine-ethanol axis. The 7th entry in the prevention protocol forces a confrontation with the two most culturally embedded yet physiologically destructive habits in human history, the inhalation of combusted tobacco and the consumption of ethanol. While often categorized under the benign umbrella of lifestyle choices, in the context of gastroesophageal reflux disease, GERD, smoking and drinking represent a coordinated chemical assault on the body's anti-reflux barriers. To understand the magnitude of this threat, one must strip away the social romanticism of the smoke and a drink and view it through the lens of molecular pathology. This is not merely about irritation, it is about the systematic dismantling of the neuromuscular machinery that keeps the stomach sealed. When nicotine and alcohol are introduced into the system, they initiate a cascade of failures that compromise the lower esophageal sphincter, desiccate the protective mucosal layers, and accelerate the transition from simple heartburn to carcinogenic cellular mutation. Nicotine, the primary psychoactive alkaloid in tobacco, is a potent pharmacological agent with a devastating affinity for the digestive tract. Its primary mechanism of sabotage is the direct relaxation of smooth muscle tissue. The LES, the crucial valve separating the esophagus from the stomach, is composed entirely of smooth muscle. Under normal conditions, this muscle maintains a resting tone, a constant state of contraction that acts as a physical barrier against the pressurized acid below. Nicotine acts as a key that unlocks this door. Upon inhalation, nicotine enters the bloodstream and reaches the brain within seconds, but it also circulates systemically to the gut. It binds to cholinergic receptors on the smooth muscle cells of the LES, inhibiting their ability to contract. This results in a measurable drop in sphincter pressure. Clinical manometry studies have shown that within minutes of smoking a single cigarette, the basal pressure of the LES plummets, creating a floppy valve scenario. This allows gastric contents to regurgitate effortlessly into the esophagus, often without the smoker even realizing it until the burn sets in. However, the damage caused by smoking extends far beyond the valve. It destroys the body's natural fire extinguisher, saliva.
Saliva is biologically engineered to be the esophagus's primary defense mechanism. It is rich in bicarbonate, a natural alkali that neutralizes any stomach acid that escapes into the throat. It also contains epidermal growth factor, EGF, a protein that helps repair injured tissue. Smoking causes chronic xerostomia, or dry mouth, by inhibiting salivary gland function. A smoker produces significantly less saliva, and the saliva they do produce is of lower quality, containing less bicarbonate. This creates a double-hit phenomenon. The nicotine opens the gate for the acid to attack and simultaneously removes the chemical shield that would normally neutralize that acid. The esophagus is left undefended, bathed in corrosive fluid with no ability to wash it away or buffer its pH. Furthermore, the act of smoking involves deep inhalation inhalation and often vigorous coughing, the smoker's cough is a violent mechanical event that spikes intra-abdominal pressure. Each cough acts as a pneumatic hammer, driving the stomach up against the diaphragm and forcing acid through the weakened LES. Enter alcohol, the second agent of this toxic alliance. Ethanol is unique because it is both a relaxant and a direct solvent. Like nicotine, alcohol is a central nervous system depressant that relaxes smooth muscle, further compromising the LES. But ethanol's local effects are even more insidious. The lining of the esophagus and stomach is coated in a protective gel of mucus and prostaglandins. Ethanol acts as a solvent, stripping away this protective mucosal layer and exposing the raw epithelium underneath to the ravages of hydrochloric acid and pepsin. It essentially dissolves the skin of the gut. Additionally, alcohol is a potent stimulant of gastric acid secretion. When ethanol reaches the stomach, it triggers the release of gastrin, the hormone that tells the parietal cells to pump out acid. A night of drinking turns the stomach into a hyperacidic reservoir. The type of alcohol matters, adding layers of complexity to the prevention strategy. Beer and sparkling wines, champagne, prosecco, introduce carbonation, expanding the stomach volume and adding mechanical pressure to the chemical relaxation. Red wine, often touted for heart health, is highly acidic and contains tannins that can delay gastric emptying, keeping the acid in the stomach longer. Spirits, while less voluminous, provide a concentrated dose of ethanol that can cause immediate chemical burns to inflamed tissue.
The cocktail often includes acidic mixers, citrus juices, or carbonated sodas, creating a beverage that is essentially a Gerd bomb, combining alcohol, acid, and gas in a single glass. The synergy between smoking and drinking is where the risk of malignancy becomes terrifyingly real. Alcohol acts as a solvent that enhances the penetration of tobacco carcinogens into the esophageal tissue. This is why the risk of esophageal squamous cell carcinoma is exponentially higher in people who both smoke and drink compared to those who do only one. For the Gerd sufferer, this is the ultimate warning. The chronic inflammation caused by reflux, Barrett's esophagus, is the fertile soil for cancer. Tobacco and alcohol are the seeds. The prevention strategy, therefore, is absolute. Stop smoking is not a suggestion to cut back, it is a physiological mandate. The half-life of nicotine's effect on the LES means that even social smoking keeps the valve in a state of partial paralysis. The cessation of smoking allows the LES pressure to return to normal levels and restore salivary function, often providing dramatic relief within weeks. Limit alcohol is more nuanced but equally critical. It requires a renegotiation of social rituals. It means understanding that a nightcap is a fallacy. Alcohol destroys sleep architecture and ensures nocturnal acid exposure. The prevention protocol demands an alcohol curfew, stopping all consumption at least 3 to 4 hours before sleep to ensure the stomach is empty and the LES has recovered some tone before the body goes horizontal. The what to do guidance for this entry is a battle against addiction and biochemistry. If symptoms are frequent, the reduction of alcohol must be aggressive. It involves identifying the specific tipping point, the glass of wine that turns a meal into a medical event. For smoking, the quit plan is essential because the stress of withdrawal can temporarily worsen reflux. Stress increases acid. Therefore, the plan must include nicotine replacement therapies that do not involve swallowing. Patches, not gum, as chewing gum can introduce swallowed air. It requires a holistic approach, recognizing that the cigarette and the drink are not friends to the stressed mind, but enemies to the burning throat. The cultural shift away from the Mad Men era of constant smoking and drinking is a public health victory, but for the individual Gerd sufferer, the battle is personal.
It is a choice between the momentary pleasure of the vice and the long-term preservation of the alimentary canal. 8. The caffeinated pressurization, methylxanthines, carbonation physics, and the modern addiction to acidity. Entry number 8 confronts the fuel of the modern workforce and the centerpiece of the contemporary diet, caffeine and carbonated beverages. In the high-speed, 24-hour society we inhabit, these substances are viewed as essential tools for productivity and refreshment. However, for the gastrointestinal tract, they represent a dual threat of pharmacological stimulation and pneumatic distension. This entry is an investigation into the chemistry of the coffee bean and the physics of the carbon dioxide bubble. It challenges the daily rituals of billions of people, positing that the very fluids we consume to wake up and cool down are responsible for the fire rising in our chests. To prevent GERD, one must deconstruct the morning cup and the afternoon soda to understand how they turn the stomach into a pressurized acid-producing factory. Caffeine is the world's most popular psychoactive drug, a member of the methylxanthine class of compounds. Its utility in keeping us awake stems from its ability to block adenosine receptors in the brain. However, its effect on the gut is less desirable. Methylxanthines are potent smooth muscle relaxants. Just as they dilate bronchial tubes, which is why caffeine was once used for asthma, they dilate and relax the lower esophageal sphincter, LES. This is a direct pharmacological hit. A strong cup of coffee delivers a dose of relaxant directly to the valve that is supposed to keep acid contained. But the assault of coffee is two-pronged. prolonged. Beyond the LES relaxation, caffeine and other compounds in coffee, such as chlorogenic acid and N-methylpyridinium, are powerful secret agators, substances that stimulate the secretion of fluids. Specifically, they trigger the parietal cells in the stomach lining to hypersecrete hydrochloric acid. The debate over regular versus decaf is a common point of confusion for patients. While decaffeinated coffee removes the methylxanthine threat to the LES, it does not remove the acidity or the other chemical compounds that stimulate astrin release. Studies have shown that decaf coffee still stimulates significantly more acid production than water. Therefore, coffee is a perfect storm beverage. It relaxes the containment valve while simultaneously overfilling the tank with corrosive fluid.
The roasting process also plays a role. Darker roasts often contain lower levels of acid, but can still trigger the hormonal release of gastrin. The prevention strategy requires a painful weaning process. It involves recognizing that the coffee jitters are mirrored by esophageal jitters. The switch to low-acid options or herbal teas is not just a taste preference, it is a medical necessity to lower the basal acid output of the stomach. However, the more mechanical threat comes from the second half of the century, carbonated drinks. The consumption of soda, sparkling water, and beer is essentially the ingestion of gas. Carbonated beverages are infused with carbon dioxide under pressure. In the can or bottle, the gas is dissolved in the liquid, governed by Henry's law, which states that the solubility of a gas is proportional to the pressure. When the container is open, the pressure drops and bubbles form. When the cold liquid hits the warm environment of the stomach, 37 degrees Celsius, 98.6 Fahrenheit, the solubility of the CO2 decreases catastrophically. The gas comes out of the solution explosively. A standard 12-ounce can of soda can release liters of gas once warmed in the stomach. This rapid expansion creates a phenomenon known as gastric distension. The stomach walls stretch to accommodate the new volume of gas. This stretching triggers a reflex known as transient lower esophageal sphincter relaxation, TLESR. The body perceives the pressure and signals the LES to open to vent the gas, what we know as a burp. In a healthy person, this is a dry vent. Air escapes, pressure normalizes. In a Gerd patient, the acid pocket sitting on top of the meal is often carried up with the gas. The wet burp or the acid mist that accompanies the gas is a direct injection of corrosives into the esophagus. Furthermore, the carbonation itself is acidic. Carbon dioxide dissolved in water forms carbonic acid. Colas are further acidified with phosphoric acid to balance the sweetness of the sugar. This means the patient is drinking an acidic liquid that expands into a gas, mechanically forcing the valve open to spray acid into the throat. The rise of healthy sparkling waters, LaCroix, Perrier, etc., has complicated this narrative. Many patients believe that because these drinks have no sugar and no calories, they are safe. This is a dangerous misconception in the context of Gerd. While they lack the fermentable sugars that cause bacterial bloating,
They still possess the physics of carbonation. The mechanical distension caused by the CO2 is identical whether the liquid is sugared cola or pure spring water. The pressure on the LES is the same. The burp reflex is the same. For the reflux sufferer, bubbles are the enemy, regardless of the calorie count. The What to Do guidance emphasizes a transition to still beverages. It requires the patient to rediscover the sensation of drinking liquids that do not fight back. Herbal teas, specifically chamomile, licorice, DGL, and ginger, offer a therapeutic alternative. Chamomile contains apigenin and bisabolol, compounds with anti-inflammatory and antispasmodic properties that can soothe the gastric lining. Ginger is a prokinetic, meaning it helps speed up gastric emptying, moving food out of the stomach faster. This is the antithesis of the caffeine carbonation effect. Instead of relaxing the valve and bloating the stomach, these alternatives soothe the valve and empty the stomach. The withdrawal from caffeine is a significant physiological hurdle. The caffeine headache is a result of blood vessel dilation in the brain. However, for the Gerd patient, this temporary pain is the price of esophageal civation. The strategy involves a slow taper, mixing decaf with regular, gradually reducing the ratio to avoid the shock of withdrawal while steadily lowering the acid load. It also involves degassing beverages. If one must have a soda, pouring it into a glass and letting it sit or stirring it to release the CO2 before drinking can mitigate the mechanical risk. Culturally, we are moving toward an era of extreme caffeine. Energy drinks with 300 milligrams of caffeine are now standard. This suggests a future wave of aggressive Gerd in younger populations. The marketing of these drinks ignores the biological reality that the human stomach was not designed to handle such potent pharmacological stimulation combined with high-pressure gas. The prevention of Gerd in the 21st century is largely a matter of rejecting the energy and effervescence marketing narrative. It is about embracing a flat and calm diet. It is the understanding that the energy gained from a double espresso or the refreshment of a cold soda is borrowed against the future health of the esophagus. The burning sensation is the bill coming due. By reducing caffeine and eliminating carbonation, we lower the pressure, reduce the acid,
and allow the body's natural containment systems to function without interference. 9. The neurological sabotage, the gut-brain axis, aerophagia, and the lost art of mastication. The 9th entry in our investigation brings us to the most complex and elusive frontier of gastroenterology, the human mind. Manage stress and slow down eating is often dismissed as generic wellness advice, a throwaway line in the medical brochure.
However, in the context of gastroesophageal reflux disease, GERD, this directive strikes at the very heart of the gut-brain axis. The stomach is not merely a muscular bag of acid, it is innervated by the enteric nervous system, ENS, a network of over 500 million neurons, often referred to as the second brain. This neural mesh is in constant bidirectional communication with the central nervous system via the vagus nerve. When we explore the relationship between stress, speed, and reflux, we are uncovering a system of neurological sabotage, where the body's survival instincts actively dismantle its own digestive defenses. The prevention of GERD requires us to hack the autonomic nervous system, shifting the body from a state of crisis back to a state of receptivity. To understand why stress triggers reflux, one must examine the binary nature of the autonomic nervous system. It operates in two distinct modes, the sympathetic, fight or flight, and the parasympathetic, rest and digest. In our evolutionary past, stress was a physical threat, a predator or a rival. In response, the sympathetic nervous system would flood the body with cortisol and adrenaline. Crucially, it would divert blood flow away from non-essential systems, such as the digestive tract, and pump it into the skeletal muscles for escape. In this state, gastric motility halts, the stomach stops churning, the pyloric sphincter tightens to hold contents in, and enzyme production becomes erratic. Conversely, the parasympathetic system, mediated largely by the vagus nerve, is responsible for relaxing the lower esophageal sphincter, LES, at the appropriate times, stimulating peristalsis and promoting the secretion of protective mucus. The modern human exists in a state of chronic, low-grade sympathetic activation. Work deadlines, traffic, financial anxiety, and digital overstimulation keep the body in a perpetual fight-or-flight mode. When we eat in this state, we are forcing food into a paralyzed organ. The food sits in the stomach, stagnating and fermenting.
Because the neural signal to digest has been overwritten by the neural signal to survive. The resulting gastric distension inevitably forces the LES open, leading to stress-induced reflux. Furthermore, stress induces a phenomenon known as visceral hypersensitivity. This is a recalibration of the pain receptors in the esophagus. Under high stress, the central nervous system amplifies sensory input from the gut. A small amount of acid that might go unnoticed in a relaxed individual is perceived as agonizing heartburn in a stressed one. The brain loses its ability to filter out background noise from the body, turning volume knobs to the maximum. This creates a vicious cycle. Stress causes reflux, the pain of reflux causes more stress, and the cycle accelerates. The prevention strategy here is not just about relaxation, it is about the deliberate activation of the vagus nerve. This brings us to the what to do protocol of deep breathing. Diaphragmatic breathing, slow, deep breaths that expand the belly, physically massages the vagus nerve as it passes through the diaphragm. This sends a potent all-clear signal to the brain, mechanically forcing the switch from sympathetic to parasympathetic dominance. Taking 10 deep abdominal breaths before a meal is not a spiritual ritual, it is a physiological reset button that prepares the enzymatic and muscular machinery of the stomach to receive fuel. However, the neurological component is only half of the equation. The mechanical counterpart to stress is speed. The modern cultural shift toward fast food, not just the type of food, but the velocity of consumption, is a primary driver of the reflux epidemic. We have normalized the al desco lunch, the car ride breakfast, and the 5-minute dinner. This behavior leads to a condition known as aerophagia, or the swallowing of air. When a person eats quickly, they gulp down significant quantities of nitrogen and oxygen along with their food. In the stomach, this air separates from the solids and liquids, forming a pressurized gas cap. The physics of the stomach dictate that this gas must be vented. The body's response is the transient lower esophageal sphincter relaxation, TLESR. The brain signals the LES to open to belch out the air. The problem, as discussed in previous entries, is that in a full stomach, the air vent often carries acid mist with it. The fast eater is essentially turning their stomach into a pneumatic cannon,
constantly pressurizing the chamber with swallowed air until the valve blows. The antidote to this mechanical failure is the resurrection of mastication. Chewing is the first stage of digestion, yet it is the most neglected. The process of chewing does two critical things. First, it mechanically breaks down food into a bolus, increasing the surface area for enzymes to work. If food is swallowed in large chunks, the result of fast eating, the stomach must produce significantly more acid and churn more violently to break it down. This hyperacidity and hypermotility increase the risk of reflux. Second, and perhaps more importantly, chewing stimulates the production of saliva. As established, saliva is the esophagus's liquid armor, rich in bicarbonate and epidermal growth factor. By chewing each bite 20 to 30 times, the individual coats the food in alkaline saliva before it even reaches the stomach. This pre-buffers the meal, reducing the net acidity of the gastric content. Slow eating also allows the satiety hormone leptin to signal the brain that the body is full, a process that takes about 20 minutes. The fast eater bypasses this signal, leading to overeating, which leads to distension, which leads to reflux. The cultural implications of this entry are profound. We have engineered a society that views eating as an interruption to productivity rather than a biological necessity. The decline of the communal meal, the rise of eating while distracted by screens, and the glorification of hustle culture have created a perfect environment for GERD.
The what to do protocol is a demand for mindfulness. It requires the patient to put the fork down between bites, a physical break on the consumption process. It requires the removal of digital stimuli during meals to allow the brain to focus on the sensory input of taste and texture, which enhances the cephalic phase of digestion, the preparatory phase where the brain primes the stomach. If reflux strikes due to stress or speed, the immediate response involves mitigating the panic response. The sensation of heartburn can mimic a heart attack, inducing terror that further spikes cortisol and worsens the problem. The instruction to use deep breathing is a triage maneuver. By forcefully slowing the respiration rate, the patient can reduce the intra-abdominal pressure caused by rapid, shallow panic breathing. It also oxygenates the blood, helping to clear the metabolic byproducts of stress.
This entry ultimately teaches us that the stomach is not an isolated machine. It is a mirror of our mental state. To heal the burn, we must first slow the world down. We must treat the meal not as a refueling stop in a race, but as a protected sanctuary of time, where the parasympathetic nervous system is granted the authority to nurture the body.
10. The pharmaceutical paradox, NSAID erosion, the PPI trap, and the red flags of malignancy. The final entry in our investigation brings us to the medicine cabinet, a place of both salvation and destruction. Use safe medication guidance is the capstone of GERD prevention because it addresses the external chemical agents we introduce to our bodies in the name of health. This segment explores the double-edged sword of modern pharmacology, the painkillers that silently eat away our stomach linings, and the acid suppressives that have become both a miracle cure and a dependency trap. It also serves as the critical bridge between self-management and oncology, defining the precise moment when a lifestyle issue transforms into a medical emergency. To prevent the ultimate consequences of GERD, one must navigate the minefield of over-the-counter drugs with the precision of a chemist. The first villain in this narrative is the non-steroidal anti-inflammatory drug, NSAID. This class of medication, which includes ubiquitous household names like aspirin, ibuprofen, and naproxen, is the most common cause of drug-induced gastropathy. The mechanism of injury is biochemical warfare against the stomach's natural defenses. The stomach lining is protected from its own acid by a layer of mucus and bicarbonate, the production of which is regulated by enzymes known as cyclooxygenase 1, COX-1. These enzymes produce prostaglandins, the chemical messengers that tell the stomach lining to thicken and repair itself. NSAIDs work by inhibiting COX enzymes to reduce pain and inflammation throughout the body. However, they are indiscriminate. By blocking COX-1, they inadvertently shut down the production of prostaglandins in the gut. The result is a thinning of the protective mucus layer. Without this shield, the stomach acid begins to digest the stomach wall itself, causing gastritis, ulcers, and severe reflux symptoms. For the GERD patient, taking an NSAID for a headache is akin to turning off the force field while under attack. The prevention strategy necessitates a strict avoidance of NSAIDs in favor of acetaminophen, Tylenol, which relieves pain without stripping the stomach's mucosal defense. If NSAIDs are absolutely necessary, e.g. for arthritis, they must be taken with food or co-prescribed with a gastroprotective agent, but the risk remains high.
On the other side of the spectrum lies the class of drugs designed to treat reflux, the proton pump inhibitors like omeprazole, lansoprazole, and esomeprazole. These drugs are miracles of modern science. They work by irreversibly binding to the H+K+ ATPase enzyme system, the proton pump, on the parietal cells of the stomach, effectively shutting down the production of hydrochloric acid. For patients with erosive esophagitis, these drugs allow the tissue to heal. However, the prevention of GERD involves using these powerful tools judiciously. The widespread availability of PPIs over the counter has led to a culture of abuse, where patients take them indefinitely without medical supervision. This creates a physiological dependency known as rebound acid hypersecretion. When the body detects that acid levels are unnaturally low, it compensates by producing massive amounts of gastrin, the hormone that stimulates acid pumps. If the patient suddenly stops the PPI, the pumps turn back on, but now they are supercharged by the excess gastrin, leading to a surge of acid far worse than the original condition. This locks the patient into a cycle of dependency. Furthermore, the long-term suppression of stomach acid is not without consequence. Acid is there for a reason, to sterilize food and aid in the absorption of nutrients like calcium, magnesium, and vitamin B12. Chronic use of PPIs has been linked to increased risks of bone fractures due to poor calcium absorption, kidney disease, and susceptibility to infections like C. difficile and pneumonia because the acid barrier against bacteria is gone. The safe medication guidance requires a strategy of lowest effective dose for the shortest possible time. It advocates for the use of H2 blockers, like famotidine for ALD symptoms, as they reduce acid without completely shutting down the pumps, or alginate-based therapies that form a physical foam raft on top of the stomach contents to block reflux mechanically without altering biochemistry. The what to do component of this entry is the most critical text in this entire document. It defines the boundary of self-care. GERD is generally a benign manageable condition, but it mimics and masks the symptoms of esophageal cancer, one of the deadliest malignancies known to medicine. The red flags or alarm symptoms are non-negotiable signals for immediate medical intervention. The most ominous of these is dysphagia, difficulty swallowing.
If food feels like it is sticking in the chest, it suggests that the esophagus is narrowed. This could be a benign stricture, scar tissue, or it could be a tumor growing into the lumen.
Odonophagia, painful swallowing, indicates severe ulceration or infection. Unexplained weight loss and anemia, low blood count, suggest that there is internal bleeding or a metabolic consumption caused by cancer. If reflux persists for more than 2 weeks despite lifestyle modifications and OTC treatment, or if any alarm symptoms appear, the what to do is to seek an upper endoscopy, EGD. This procedure allows a gastroenterologist to visually inspect the esophagus and take biopsies. This is how Barrett's esophagus is detected. Barrett's is a precancerous condition where the pink, squamous lining of the esophagus is replaced by salmon-colored intestinal-like columnar cells. This metaplasia is the body's desperate attempt to protect itself from acid, but these mutated cells have a higher propensity to become malignant. The tragedy of esophageal cancer is that it is often detected too late. The prevention of death from GERD lies in the early detection of these cellular changes. The philosophical conclusion of this entry, and indeed the entire list, is that the body is a resilient but finite system. We can push it with bad food, stress it with fast living, and numb it with painkillers, but eventually the biology will break. The safe use of medication is about respect for the potency of chemistry. It is about understanding that a pill can mask a symptom while the underlying pathology deepens. The ultimate prevention is knowledge, knowing what the drugs do, knowing what the symptoms mean, and knowing when to surrender control to a specialist. In the final analysis, preventing GERD is an act of architectural restoration. We must rebuild the barriers we have torn down. We reduce the pressure, weight, clothes, meals. We reinforce the defenses, posture, sleep, saliva, and we eliminate the saboteurs, smoke, alcohol, stress. It is a comprehensive lifestyle overhaul that demands discipline, but the reward is silence, the absence of the burn, the preservation of the voice, and the longevity of the vessel that sustains us.